Assalamu alaikum. Good morning, everyone, and thanks to the organizing committee, Dr. Absi and Dr. Asker, for inviting me today. I think whoever attended last night talk by Dr. Ayman and Dr. Ghazi on the PITES will consolidate his knowledge on the same topic. We will readdress the issue of bispecific T-cell engagers in the field of multiple myeloma. Just waiting for the slides. As you all know, the patients with relapsed refractory myeloma has many options nowadays. We are living in a transformative era where the bispecific T-cell engager and T-cell redirected therapies such as the CAR T-cell therapy are addressing an unmet medical needs in the field of relapsed refractory myeloma, and more specifically on the triple class refractory patients. Can we move on with I can talk without the slides if you want. So you all know that the triple class refractory patients who failed IMiDs, immunomodulator, proteasome inhibitor, based on the locomotion trial that looked into the patients who were triple class refractory. It was a prospective, non-interventional, multinational study looking at the real-world current standards on the triple class refractory patients, where they included around 250 patients who were triple class refractory. And as you can see here, the median progression-free survival is around 4 to 5 months, and those patients usually live for 1 year. So this represents an unmet medical needs. Moreover, the triple class refractory are evolving and growing in the early relapse refractory setting of myeloma, where we can see from this survey in 2020, they said that the triple class refractory in the second line is around 20%. And now I think more and more we're using the CD38 monoclonal antibody in the frontline setting, making the triple class refractory in the second line treatment is approaching, I would believe, 50 and 60%. As you know, the myeloma cell can be eliminated by bispecific T-cell engager through the T-cell activation, proliferation, and cytokine production. And we have 3 approved medication by the FDA, the teclistamab on October 25th, 2022, where they approved the first bispecific in patients who failed at least 4 prior lines of therapy. And a year later, in August 2023, on the same month, they approved 2 medications, one anti-BCMA, which is elranatamab, and the other one, which is an GPRC5D bispecific T-cell engager, talquetamab. Now, these bispecific T-cell engager, usually the patients will respond in a proportion of around 2/3 of them, they would have good response. 1/3 of the patient might have a refractory disease from the get-go, and majority of patients who were responding will have eventually relapse through the acquired resistance mechanism. Now, the teclistamab was approved based on the Majestic trial, which was an open-label dose escalation phase 1/2 trial, where the patients who were triple class refractory included. And as you can see here, the median prior lines of treatment was around 5. 80% of the patients had a prior transplant, and all patients were triple class refractory. With this heavily pretreated patients, the overall response rate was around 63%. Majority of the responses were deep responses, VGPR or more, but there are 3 groups of patients who stood to be refractory and have an inferior outcome, such as patients with an ISS stage 3, patients with extramedullary disease, and patients with high plasma cells in the bone marrow of more than 50%. Those who responded had a median duration of response of around 18 months, and the median PFS for the whole cohort was 11.3 months, and the median overall survival for this heavily pretreated patients was 18 months. Now, 40% of the patients died during the study, mainly due to progressive disease. Now, what does the teclistamab do in the real-world data? This is an investigator-initiative retrospective analysis of 123 patients from Germany who at least received 1 prior full dose of teclistamab from 18 German centers. Between July 2022 and October 2023, they included 123 patients. We can see that those patients in the real world, they were a little bit heavily pretreated than those in the study Majestic 1. They had more median prior lines of therapy, more extramedullary disease, and more high risk as per the ISS staging system. With a short follow-up of 5.5 months, we can see that the median overall response rate was around 60%, median PFS of 8.7 months, and the median duration of response and overall survival was not reached. Now, when it comes to the subgroup analysis, the patients who were pre-treated with ide-cel in the past, they have inferior overall response rate of around 33% in comparison to those who were not treated with ide-cel in the past. Notably, the anti-BCMA therapy was only noted to the CAR T-cell therapy, but not to the patients who had belantamab mafodotin, which is an antibody-drug conjugate against BCMA. The PFS was also noted on the subgroup analysis on multivariate and univariate analysis that the patients who had an ISS stage 3 and bone marrow infiltration of more than 50%, again, they have an inferior outcome as per the real-world data. The safety outcome here was comparable to what's been seen in the Majestic 1 trial. We can see a very high rate of infection, high rate of CRS, but mainly grade 1 and 2, lower rates of ICANS of 7%, neutropenia and anemia thrombocytopenia were noted. TPO and GCSF were given to a group of patients on the study. The median hospital stay here was around 10 days. Most of the patients were able to go home. 7 patients required ICU admission either because of CRS, ICANS, or infection or other complications. Now, the French have examined the use of teclistamab on the dialysis patients. They included 13 dialysis patients, and the median prior lines of those patients was 4. They used a similar CPAP dosing schedule. However, the teclistamab was given 1 or 2 days after the dialysis. They had similar outcome to non-dialysis patients. Therefore, the teclistamab is feasible in patients who are on dialysis. This is the dosage and administration as per the FDA label. So where are we moving with the teclistamab in the future? In the future, the teclistamab, the Majestic 3 trial, is testing the teclistamab with daratumab in the relapsed refractory setting in comparison to the Dara-PD or Dara-VD. The Majestic 4 trial also testing the teclistamab in newly diagnosed patients, in addition to lenalidomide in the maintenance setting after autologous stem cell transplantation. Now, Majestic 4 trial is a study comparing teclistamab in combination with daratumab, lenalidomide, in patients who were newly diagnosed transplant ineligible. As we know that the Dara-Revlimid-Dex is an approved protocol for the frontline setting. It's been used now, I think, in every patient who has access to monoclonal antibodies. The Majestic 9 trial is another phase 3 trial comparing the teclistamab with as a single agent in comparison to the patients who failed Dara in the past. So those patients who failed Dara in the past, they were randomized to either teclistamab versus pomalidomide Velcade-Dexa or KD. I'm not sure why they use the doublet combination here, but not the KPD, for example, in this study of Majestic 9 trial. Now, moving on to another anti-BCMA, which is the elranatamab, which is based on the Magnetism 3 trial. They included 233 patients who failed at least one IMiD, PI, or monoclonal antibody. The CPAP dosing schedule was given at day 1, 4, 8, and then weekly thereafter. The primary endpoint here was the overall response rate. The secondary endpoint was the time to response, PFS, OS, and safety. As you can see here, they included 123 patients with a median age of around 68, median prior lines of therapy of 5, 70% of the patients have had transplant in the past, and all the patients were triple-class refractory. With the single-agent elranatamab, the overall response rate was around 60%, and we can see a deep remissions among the responder up to 60%. The patients who achieve CR or more, they tend to have a longer duration of response and longer progression-free survival. Again, similar poor responders among the BITE, high plasma cells in the bone marrow, high risk ISS staging, pentarefractory, and extramedullary disease. They still behave poorly, and I think this represents an unmet medical need. Now, the PFS data and OS data from the ASH 2023 was reported to be at 17.2 months, the median PFS and median OS of 21 months. Now, what are the safety profile with the elranatamab? The anemia and neutropenia is very common. We can see here 69% of the patient developed infection, and 40% of those were grade 3 and 4 infection. 6.5% were fatal infection. Immunoparesis was noted almost on all patients. Patients who developed a severe hypogammaglobulinemia was 75%. Therefore, I think the supportive care that we'll be touching upon soon on the infection part. The cytokine release syndrome was also noted in the first 3 CBUB dosing schedule, but not after the 4th dose, at a rate of 70% in grade 1, 2, and no grade 3 or 4 toxicity. The ICANS reported at a very low rate of 3.4% as well. Here is the dosage and administration of elranatamab, day 1, 4, 8, and then weekly. And once you reach cycle 7, which is week 25, then you can move it every 2 weeks. The monumental study have tested the patients with GPRC5D talquetamab on 232 patients. The median age was 64, median prior lines of therapy of 6, and that 1/3 of the patient had an extramedullary disease in the past. So again, overall response rate very high, 70 to 72% among the sub-Q and IV administration. We can see very high rate of VGPR or more. However, the grade 3 and more infection is noted here again. Hypogammaglobulinemia is noted. Very low rates of ICANS again. The CRS, thankfully, it's mainly grade 1 and 2, and I think we are in a better position when we did the studies on the myeloma than before, because the bispecific T-cell engager has been approved and used extensively in the field of leukemia as well as lymphoma. Now, what's peculiar about the talquetamab is the on-target toxicity, because the GPRC5D is expressed on the keratinocytes, so it can cause nail dystrophic changes and palmar keratoderma, for which the monumental modified dosing schedule was proposed. This is a prospective cohort of patients who were responding to talquetamab, and then they tried to reduce the dose from the 0.8 milligram per kg every 2 weeks to 0.4 milligram every 2 weeks, or they move the regimen every 4 weeks instead of 2 weeks. So the talquetamab dose reduction typically occurred after achieving a response. The median time to dose reduction was around 3 months in general. Most patients who underwent response dose reduction maintained the response, with a median follow-up of around 27 months, the median duration of response of around 20 months. Again, the median time to dose reduction following a response was 3.1 months. The overall response rate among those patients was 80%. The outcomes in these cohort of patients was observed on the 0.8 milligram per every 2 hours registration, was comparable to what was seen in the registrational cohort. Now, this is the anti-BCMA bispecific in the myeloma, where we have 3 approved medication, and I think we have 4 to come in the pipeline. BCMA density at the time of relapse usually reduce, which makes sometimes the other immunotherapy or T-cell redirected therapy difficult in this group of patients, as this correlative analysis study done from the Majestic-1 trial. Now, monitoring prophylaxis and treatment of infection is very, very important in this cohort of patients, and this is, would refer you to a very nice review article published at the Blood Cancer Journal last year, where you can see that the patients with myeloma have a 7 times higher risk of bacterial infection and 10 times higher risk of viral infection. And the infection usually happens in the first 3 months of diagnosis or in the relapse refractory setting. It depends on multiple factors, the patient-related factors, the disease-related factors, treatment-related factors, and also the infection history. As you can see here from all the studies that we have on the PITE, that we can see that the grade 3 or more, not any grade, it's ranging from 20 to almost 50% of infection. Therefore, this is a pooled analysis from all single-agent bispecific antibody used in the multiple myeloma. They included in this meta-analysis 1,100 patients where they had 70% were anti-BCMA and 30% were the other, either GPRC5D or FCRH5. The median prior lines of this meta-analysis was 5, and the median follow-up was 6 months. As you can see here, the infection rate on this cohort, on this meta-analysis was 50%. Grade 3 and 4 pneumonia was 10%. Grade 3 or 4 COVID infection was 11%. Neutropenia was very common, and mainly grade 3 and 4. Another French analysis, they looked at the cumulative incidence of infection following bispecific T-cell engager. What was noted here that the rate of infection was lower among the patients who received GPRC5D antibodies in comparison to the PCMA, 73 versus 51%. Most of the infections were bacterial, 56%, 38% were viral, and 5% were fungal infection. Important measures to take is the IVIG administration, prophylactic antibacterial, antiviral, and vaccination. As you can see here, we knew that the baseline, there will be a drop in the immunoglobulins from the baseline. Therefore, I think we have to anticipate this and be proactive and start the IVIG promptly, because it will significantly reduce the rate of infection by almost 80%. So neutropenia is common, 70%, 65% were grade 3 or 4 neutropenia, and usually it occurs late during the treatment, is around 2 to 3 months. GCSF can be used, but here you have to be careful, because the GCSF should not be used during the step-up dosing schedule. You have to use it after you achieve a response, or at least after the dose number 4. Before starting treatment with bispecific, I think we have to take things in consideration: the functional status of the patients, taking a very comprehensive medical history, vaccination history, and whether the patient had previous infection, latent infection, etc. And whenever you suspect infection, then fever is there, then an early intervention with broad-spectrum antibiotics, and then tailor your treatment according to the microbiological confirmation. We have to do all the basic lab imaging modality that's possible, and sometimes we need to do some biopsies. So the take-home message here, I think, from the infection and PITES, the monthly immunoglobulin monitoring is important. Keeping the immunoglobulins above 400 milligram per deciliter. Prophylax the patients with antiviral, anti-BGB. Bacterial prophylaxis is recommended for patients who were having prolonged neutropenia. Fungal infection in general is not recommended. However, it should be considered for patients who had steroids, who had prolonged neutropenia, or who had a prior history of fungal infection. Now, the mechanism of resistance here, we will look into it into two things. The first, primary refractory patients. They can have it either because of the disease burden that we discussed earlier, high risk ISS stage 3 or more, high plasma cells at the time of the infusion, or the patients who had an extramedullary disease. The other potential cause for primary refractoriness is the soluble BCMA. We know that the BCMA is a cell surface protein. However, it can be cleaved and be present in the serum because of the gamma secretase enzyme, which can cleave the BCMA from the cell surface, and the soluble BCMA will be in the serum. Therefore, when you give the teclistamab or other anti-BCMA, there will be what we call it a sink effect, that the teclistamab will bind to the BCMA in the serum and will not reach to the cell surface protein and causing cytolytic activity on the myeloma cell. Therefore, there is two ongoing studies, the Magnetism-4 and Majestic-2 trial, trying to address this issue by combining the teclistamab and elranatamab with the gamma secretase inhibitor in order to overcome this effect of sink effect. The other mechanism that we can overcome and this has been validated from clinical studies, is to increase the dose of the teclistamab or design the teclistamab to bind only to the full length of the BCMA, but not the soluble BCMA in the serum. Another mechanism of primary refractoriness is the T-cell fitness. So T-cells are exhausted, and from the Majestic-1 correlative analysis, when they looked at the T-cell function, they found that the T-cells that are expressing PD-1 or TIM3, usually they have a lower response rate in comparison to the PD-1 negative, TIM3 negative. The relapse usually happens due to an antigenic escape, and this is mainly due to deletion or mutation at the BCMA in 40% or almost universal in GPRC5D. Therefore, a redirect TT trial is addressing the sequential use of the teclistamab followed by talquetamab with an overall response rate of 96%, and in patients with extramedullary disease, the overall response rate is around 81%. So with that, the take-home messages: the bispecific T-cell engager is effective in triple-class refractory patients. They are less effective in patients with ISS stage 3, extramedullary disease, and high disease burden diagnosis. Very high rate of infection. All precautions should be taken. CRS is common. However, this is mainly grade 1 and 2. ICANS seems to be manageable with a low grade. We have different bites. I think sequencing is still to be determined, and several ongoing trial testing its combination with the other agents in earlier lines of treatment. With that, I thank you so much for listening.